Hey guys, it's me, Dr. Samina Rahman, Gyno Girl. Welcome to another episode of Gyno Girl Presents Sex, Drugs, and Hormones. I'm Dr. Samina Rahman. I'm a board-certified gynecologist in Chicago, Illinois, and I'm a menopause and sexual medicine specialist. And I'm so excited to have another episode with you guys. Please like my channel, give it a rating, tell me something else you guys want to hear. Leave some comments. I'd love for you guys to leave some comments as well. But today, you guys are in for another treat. I have another amazing orthopedic surgeon. I interviewed Dr. Vonda Wright. You guys have heard. This is another orthopedic spine surgeon who is involved in the sexual medicine world tremendously, and he is breaking ground with Dr. Irwin Goldstein. You guys heard me talk to Dr. Irwin Goldstein and Sue Goldstein a few episodes ago, and this guy is amazing. He's killing it. He is one of the sex med specialists that works on the spine. Remember when we talk about sexual medicine and pathology related to pelvic dysesthesia, so abnormal pain sensations in the pelvis, or this persistent genital arousal disorder, or clitoridynia or vulvodynia, we look at where the source is. What is the source of the pain? What is the pain generator? Where is it? Or is it in more than one place? And remember, we do a region-based approach to this, right? So region 1 is your end organ. End organ would be the clitoris, the vestibule, the vulva, the labia minora, the labia, we're looking at the full end organ itself. You're looking at vulvar dermatology. You're looking at whether or not hormones are involved. You're looking at all the things when it comes to the clitoris. Are there clitoral adhesions causing keratinized pearls that cause clitoral pain or persistent genital pain? So there is region 1. Region 2 is always treated in every category that I've ever used. But region 2 is your pelvic floor. Pelvic floor therapy is integral to treatment of pelvic floor dysesthesias and PGAD. So these abnormal pain sensations, these abnormal arousal sensations, have to be treated with the pelvic floor because you're likely clenching. And sometimes the hypertonicity of the pelvic floor causes issues with how the pudendal nerve traverses in the pelvis, and that needs to be treated. So you have to do pelvic floor therapy, period. That is involved. Region 3 is your cauda equina. That is your lower part of the spinal roots in the spine. And region 4 is your lumbar sacral region, right? So we are talking about these regions, and region 5 is your brain. And each of these regions is critical in evaluating and sometimes treating multiple regions to find out why it is you or your patient has genital dysesthesias, these abnormal pain sensations in the pelvis, or they have a persistent feeling of arousal that is not associated with sexual thoughts or fantasies. So we have to be sure what's happening and where it's happening. And most of the time, we're treating multiple regions to see what is going to give you or your patient pain relief. But today, I'm talking to the OG of region 3 and 4, which is your spine, right? The spine has all of the nerve roots that then eventually end in your pelvis and end in your genital region. And so I'm talking to Dr. Choll Kim. He's a Harvard graduate. He's a double board certified minimally invasive surgeon. He's a minimally invasive spine surgeon to boot, which we don't see a lot of those a lot of times. He is the founder of the MISCOE, Minimally Invasive Spine Centers of Excellence, and former president and founder of the Society for Minimally Invasive Spine Surgery. Most importantly, he's an internationally recognized as an expert in the field of computer-assisted minimally invasive spine surgery and a world leader in laser endoscopic spine surgery, LESS. Dr. Kim utilizes these state-of-art minimally invasive treatments to effectively treat all aspects of complex spinal disorders, including herniated disc, annular tears, radiculopathy, sciatica, and spondylolisthesis. His distinguished background allows him to successfully treat patients once suffering with life-debilitating back pain, but also life-debilitating sexual dysfunction. He prides himself in treating patients like family and providing concierge-style medicine to ensure his patients receive the most appropriate treatment plan to regain their quality of life as soon as possible. He's amazing. He has been pivotal in the understanding of the spine when it comes to sexual dysfunction and works in San Diego in his own center and in conjunction with Dr. Erwin Goldstein in the Sexual Medicine Center in San Diego. So we're going to talk about how this evolved with our understanding of the spine and his work with Dr. Goldstein and his work with tears of the annulus of the spine, as well as, how Tarlov cysts, which are epidural cysts of the spine, can be anywhere in the spine, and they're just these fluid-filled cystic sacs and can cause some distress, but sometimes are just incidental. So we're going to talk to him. So let's get at it. Hi, everyone. Welcome back to another episode of Gyno Girl Presents Sex, Drugs, and Hormones. You guys are in for a big treat today. I'm super excited to have this is my second orthopedic surgeon on this podcast, actually. An amazing surgeon who I have a lot of respect for, and he's just like the coolest guy ever. You guys heard my intro. This is welcome, Dr. Choll Kim. I'm trying to be like Oprah now.
I love that.
Oh, welcome, Choll. So happy to have you here. I met Choll actually, you guys hear me talk about Ishwish all the time. I met him at the International Society for the Study of Women's Sexual Health. Probably, did we meet in Dallas or did we meet in St. Louis? I don't know. It was years ago. And, there aren't that many surgeons that come, like, I guess, orthopedic and neurosurgeons that would come to the Ishwish conference. And he's trailblazing, man. He's leading the way here. So we're going to talk to Dr. Choll Kim today about what brought him into the world of orthopedics, and then more importantly, what brought him into the world of sex medicine that we want to hear about. But I've talked actually about how the spine is so important in our evaluation. You guys have heard my discussion with some of my patients who have come on that have spinal injuries, and I had April on the podcast too, and she talked about her annular tear. And she talked about you at that time with her PGAD symptoms. But first, Choll,
She
tell
was
me
one
about
of my very first patients.
right. Oh yeah, there you go. See, so and that podcast, like I had so many people reach out to me about, because the PGAD isn't often discussed enough, and the fact that she was so forthcoming about her own journey, and then she's now like someone that treats it, in the pelvic floor area. So.
What's interesting is that I did a survey of my regular spine patients, not the patients that are referred to me through our sexual medicine program and Dr. Goldstein. And probably almost 10% of patients have some degree of significant sexual dysfunction. But had I not administered this questionnaire in kind of like a kind of private setting, we probably would have never known. But
Yeah. Isn't
10%,
that amazing?
it was
Yeah.
actually 8%, but that's a lot.
It's a lot. I think maybe I told you this story before, but when I started my practice 10 years ago, my husband's an interventional pain sports medicine through PMR, but he does all the, injections in the spine. And so he was like, I got to teach you a little spine so that you know who to refer to me. And then I'll know that I can refer, to you as a gynecologist. I know what you do. And so he taught me how to do like a brief spine evaluation and question the patients about other radicular symptoms. And in the beginning, I had all these patients that had like either interstitial cystitis or, weird vulvar pain. And they also had this radicular symptoms. So I was like, oh, well, they also have this spine stuff, have other radicular symptoms, I should say. Whether or not it was like tingling or numbness down their legs or like, weakness or whatever. And, I would send them for an MRI and then send them to my husband. And then he would treat them with, whatever caudal epidural, whatever thing he did. And the symptoms would improve, like, and it was like, oh, so like, that was my first epiphany before like I should have published it back then.
Okay. What's funny is that I had a very similar experience. I did a surgery on a patient with back pain shooting down their leg. This person happened to work in Dr. Goldstein's office. She had a facet cyst and severe radiculopathy and back pain. I did her surgery and she got better in terms of back pain and radiculopathy, which I fully expected.
Yeah.
But you know what she said after that?
What?
She said, Dr. Goldstein, I've never told anybody this, but I have pelvic dysesthesias, like a form of PGAD.
Yeah.
And I didn't really say anything about it, but that's better now after Dr. Kim's surgery.
I love it.
And that's probably what really motivated Erwin and me to like go after this in earnest, because until then, we kept just going back and forth. Yeah, maybe we should do this. Maybe we should do that. After
Yeah.
that, we started having weekly meetings, going
Yeah.
through MRIs.
Yeah.
And it's a very interesting story of how I became um, a part of this community, which,
Yeah.
by the way, the Ishwish and sexual medicine community, I'm around a lot of physicians, but this is the most dedicated, the most
That's
caring,
funny. That's fu-
and the most energized and cooperative group of physicians I've ever seen
Me
together.
too.
When I go to Ishwish, I'm just energized because the effort is like there's a whole energy going in the same direction. Everyone is just focused on taking care of this really bad problem. And I've thought about this myself. If I had to decide between a sexual disorder and a drop foot or radiculopathy, it wouldn't even be close. I'd be like,
Right.
give me the drop foot.
Yeah. No
You
kidding.
never think about it until you
Yeah.
really seriously think about it. It's a huge deal.
It's a huge deal.
Um, so I
Yeah.
get it, and I'm really lucky I came into this world. But had it not been for Dr. Goldstein
Mhm.
being on the same campus as me and him badgering me, because for anyone that knows who Dr. Irwin Goldstein is, probably the father of sexual
Father, yeah.
medicine in this country,
Yeah.
he is relentless. Once he decides on something, he's not
He
going to let
keeps
it go.
going.
And
He keeps going. Well,
and
tell me how you met him, and then because you kind of already described one of the patients, the first patients you had, but tell me how you guys met and, like, when that
well, I knew about him because I got recruited in part by the owner of the hospital that he was at, away
okay.
from UCSD
The Alvarado
in,
one?
to Alvarado,
Yeah.
which is a small community hospital. And I was thinking about leaving, and my two practice partners back at that time was also recruiting me. But the owner of the hospital, um,
Where were you
and
before that? Oh,
I was at UCSD at the
you
university.
okay, gotcha.
I've been in academics for the
Yep.
majority of my career, but the last 15 years I've been in private practice.
Okay.
And by the way, being in private practice and being academic is not necessarily mutually exclusive.
Agreed.
In some ways, you can be more academic in private
I
practice.
I
Anyway,
agree. I agree.
they recruited me, and Irwin had this kind of the same obstacles and challenges doing what he's doing in sexual medicine as I was in minimal invasive surgery. I
Yeah.
started society. I was doing stuff that no one else was doing, and he was doing the same thing. So
Mm.
he recruited me there, so I knew about him.
Yeah.
And every time I saw him, I'd say, "Oh, hi, Dr. Goldstein." And
Yeah.
one day he said, "Choll, I need to meet with you because I think some of my patients that have PGAD," and he told me what it was. And I thought, wow, I choked around
Yeah.
probably.
Of course. Yeah.
I think it's coming from the spine. And I said what almost all spine surgeons probably have said to a multitude of our mutual patients.
Yeah.
That's crazy. I've never heard of such a thing.
Right.
And he kept badgering me and badgering me and badgering me. Then he sent me his employee. This patient has,
Yeah.
one of my employees can barely stand and sit to work.
Uh-huh.
And so I did her surgery and she got better. And then he came to my office with a stack of MRIs. He waited in my waiting room while I finished clinic. I told him I'd be done at 6. I'm never done on time. He
Yeah,
waited
yeah.
until like 7:30,
Oh,
and we
wow.
went through imaging studies and we went, maybe we
Wow.
have something here. And little
Amazing.
by little, we started very carefully
Mhm.
selecting specific patients, doing targeted injections, and then doing the most minimally invasive surgery possible. And guess what happened? Patients that have seen multiple doctors, have had multiple surgeries, multiple treatments without success, they got better. It was
Mind-blowing, great.
life changing for
Absolutely.
both the patient and for me.
Right.
And we've kept this up. There's still a very challenging group of patients, but this is absolutely real.
Yeah.
Um, it
And I
just
think it's
requires a lot of work
a lot of work.
identifying the correct patient that
Right.
has an actual spine related sexual difficulty of some type.
Right.
If you think
Yeah.
about it, it makes perfect sense. I mean, it's all about
Nerve
sensations,
yes. Nerve
experiences. All that
everything.
it has to go through a nerve.
Yeah.
And in
Yeah.
there's going to be a group of patients where that problem is because there's something wrong with the nerves in the lumbar spine. I'm
Right.
sure it goes all the way up, even to the
Yeah.
brain, but
Yeah.
the lumbar spine is the easiest thing to work on first. And we've had some of my happiest patients are my patients that I get from people like you and Dr. Goldstein.
Yeah. I think what's amazing is it really changed the paradigm of how we look at genital pelvic pain, right? Like, because at that point, it was all like, okay, just look at the vagina, the vestibule, the clitoris. Maybe you look at the pelvic floor a little bit, but the spine, that region 3 and 4. And the brain, obviously, we always kind of knew was involved, but 3 and 4, like that's huge actually. To now have a paradigm like this is like now we have an algorithm to kind of think about how to identify what patients might benefit from the things that you're describing. And you're totally true in saying that not every patient with a Tarlov cyst is going to have, sexual disorders or, PGAD, but there are those subsets, right, that benefit. Can you tell us a little bit about that? Like how we can differentiate those?
Yeah. So one of the ways that um, all this happened is that Dr. Goldstein saw a study by Dr. Barry Komisarak, neurophysiologist at Rutgers, also in his own right a sexual medicine expert, but he's a PhD neuroscientist, and he noticed that in a high proportion of patients with PGAD, persistent genital arousal disorder, you know, which is probably a constellation of things, but anything related to like sexual dysfunction and orgasmic dysfunction,
Yeah.
he noticed that an unusually high number of his patients had Tarlov cysts on their pelvic MRIs. So he made the correlation. Maybe patients that some of these are due to Tarlov cysts. And when Dr. Goldstein saw this paper, they talked, and that's what motivated Dr. Goldstein to reach out to me. And our initial look at all this was specifically to look for patients with Tarlov cysts.
Mhm.
But in the process of doing so, we saw that a lot of them did not have Tarlov cysts, but they had all these like annular tears and disc herniations and degenerative changes and stenosis in the lumbar spine. Because
Right.
you often get the same images, you get those images on the same sequence.
Right.
So we thought, okay, if Tarlov cysts can cause a neurologic disorder, maybe the disc can cause a neurologic disorder.
Right.
Either way, we have to figure out if it's true or not. Because here's what's weird about the spine.
Yeah.
You could have an annular tear, you can have a herniated disc, you can have a Tarlov cyst and not even know it. In other words,
Yeah.
a lot of abnormal findings on an MRI without symptoms.
Right.
That probably happens a lot in other
Yeah.
areas of medicine, but in
Yeah.
the spine, it is really common. So
Yeah.
somebody in my age group in their 50s, if we just took 100 people in their 50s and 60s and offered them a free MRI, half of them will have stenosis, herniated disc, annular tears, and they don't even have any symptoms. But saying that is not the same thing as saying all abnormalities are asymptomatic, because in a sea of asymptomatic abnormalities, there's going to be that one patient that has a symptomatic problem. And so if we have a way to identify a symptomatic abnormality from an asymptomatic abnormality, which look identical on MRI, then we have something. And there's a way.
Yes.
If you do a targeted injection at that disc,
Mhm.
and you bathe it with an anesthetic and a steroid and ask the patient, do they get temporarily better? That is pretty good insight as to whether or not it's symptomatic. And
Mhm.
a patient that says, I didn't notice any difference, we decide they're probably not, they probably don't have a problem due to the spine. But in patients that say, oh, I got temporarily better, that's
Yeah.
never happened before. That's a
Yeah.
positive diagnostic response. And in
Yes.
those patients, if we operate on them, they get a lot better. So I would say that there's a multitude of steps to take a huge sea of patients that you don't know exactly what's going on and whittle them down to that few patients, the remaining patients that actually have a spine problem that if you treat it will get better. And that starts with an initial assessment by a sexual medicine expert, because I don't know how to do it. And
Right.
it's pretty clear to me that most of these problems are not due to the spine. Most of them are due to other things. We
Right.
call it region one, like
Yes.
local,
Right. Yeah.
be hormonal. It could be a variety of like anatomic things in the
Mhm.
pelvis. Um, and you treat those patients with the most common causes, and you just keep willing them down to the patients that don't get better.
Yes.
And we have a very kind of regimented program. So somebody like you or Dr. Goldstein, they do the first pass. They treat the patients with the non-operative treatments that are the most obvious.
Mhm.
And the ones that get better, great. The ones that don't, they get more testing. And we even do something called neurogenital testing. That's what Dr.
Yeah.
Goldstein does.
Yeah.
It's like 3 different exam tests with like temperature probes, like little pins,
Yeah.
vibration sensors, cold temperature monitors. He even puts like a balloon inside crevices and inflates them up to see if you can notice these things. And he creates like a map of where he thinks the abnormality is. And he can kind of whittle it down to like region 3.
Yeah. Yeah.
And he
This is
sends me the region 3 patients, and then I take a crack at it. I
Mhm.
talk to the patient, I talk to them about all their other symptoms, and then I decide whether or not it's reasonable to do a targeted injection, and I order that. And I see the
Mhm.
patient afterwards and interrogate them about the response. And every one of those steps, at least for now, I wouldn't know which ones to take out. You just have to go through all those steps. And with that,
Mhm.
our surgical success has been on par with some of my happiest patients, like my discectomy
Absolutely.
patients.
Absolutely.
So
For
it's
those for
been,
those listeners that might not have listened to my other podcast around PGAD and Tarlov cyst, can you explain like what causes a Tarlov cyst, or how do people get these like spinal, you know, anatomic issues that might come up?
well,
As if we knew.
no one really knows why you get Tarlov cysts. I'm embarrassed to say it's one of those
No.
things like we just don't know.
Yeah.
There's probably a genetic predisposition. There's
Mhm.
probably a little bit of serendipity and bad luck, but no one really knows why these cysts pop up. But it's probably related to some subtle collagen disorder because there are cases of patients that have multiple Tarlov cysts all throughout their spine.
Right.
And it's very likely that patients with like Marfan-like syndrome, like Marfan's syndrome, is a
Yeah.
very specific genetic disorder of collagen type 1.
Mhm.
Yeah,
Mhm.
like a specific genetic defect. But there's probably like all these variants, and patients like that have really loose connective tissue. They
Mhm.
can hyperextend their elbows. Some people can like push their thumb all the way down to their forearm. Oh,
Oh,
can you do that?
no, I can. I like
Um,
the patients, and then they're showing.
And it's likely that it's a combination of those two things. What's interesting though is what makes an asymptomatic Tarlov cyst symptomatic?
Right.
And it's probably two things. The most obvious thing is that they grow and grow and grow, and they get so huge that something's wrong,
Right.
like a nerve gets stretched out, or the hydrostatic pressure inside the nerve sheath is so high that it affects the nerve, just the size.
Right.
But I would say that the majority of symptomatic Tarlov cysts start becoming symptomatic way, way before then. So
Yeah.
probably what happens is some bad luck event triggers an inflammatory response.
Mhm.
And then that inflammatory response turns on. And for most people, it turns back off again because as
Mhm.
things get abnormal in the body tries to heal it. And
Right.
every healing response goes through at least inflammation. So in most cases, it turns on and turns off. But every once in a while, it turns on, it does not turn off. It just stays chronically on. And by the way, that happens all the time. Anybody that's had tennis elbow, golfer's elbow, plantar fasciitis, shin
Yeah.
splints,
Yeah.
rotator cuff tendonitis, those are all chronic inflammatory conditions that um, on imaging studies, they barely have any, like, it barely looks like anything,
Yeah.
but it is really, really painful
Yes.
and
Yeah.
it lasts forever.
Uh,
So
Go
that's
ahead.
probably what happens. A little bit more complicated than that because when I do Tarlov cyst surgery, the amount of inflammation is like visibly obvious.
Yeah.
Everything's stuck down. And
Uh-huh.
then I can even see like a nerve sheath right next to a Tarlov cyst, and it's red right there
Oh, really?
because of
Okay.
increased vascularity.
And you do
So
all
I
yours through scope, right? Minimally invasive. Can you talk about a little bit how you approach these trial systems?
um, all the surgeries that I do, I try to use some type of minimal invasive techniques. So the
Mhm.
most extreme one is when I use the endoscope, like
Yeah.
you use in the shoulder or the knee.
Yeah.
But for Tarlov cysts, it's not ready for endoscopic treatment. So I still have to make a little small incision, and I
Uh-huh.
make that incision as small as possible by using navigation, so that even before I make the skin incision, like in my car, I know exactly where everything is in three-dimensional space. And as I go down, I know exactly where I am. So using that and specialized retractors. And treating the cyst earlier rather than waiting until
Mhm.
it's way too big or
Mhm.
waiting until a patient's incontinent by doing
Mhm.
these targeted diagnostic blocks. You can do the surgery with the minimum amount of trauma, minimum amount of like reconstruction. So sometimes when the cysts get really big, you have to like deal with the bone erosion and you have
Yeah.
to wrap the cyst in like a membrane and do a lot more extra stuff that makes the surgery much bigger and much more difficult to recover from. So MIS is like a combination of early detection, using intraoperative computer navigation and imaging to know exactly where you are at all times without having to like look down anatomically, and then using all the specialized kind of retractors and instruments in the operating microscope to try to be as gentle as possible and minimize collateral damage. When you do that, so far, every patient goes home the same day, and the complication rate has been zero, and the recurrence rate has been zero. I'm sure at some point
Yeah.
I'm going to have a complication because it's not possible to avoid it
Persistent memory.
um, at some point, but it's vastly different than what I expected because the literature on Tarlov cyst surgery is filled with horror stories because
Right.
traditionally Tarlov cyst surgery was done way too late, like
Yeah.
way, way too late.
Yeah. Yeah.
Either they're so huge that they erode into the bone or the patients show up incontinent of urine. And urinary incontinence is one of those really sensitive markers. Once that happens, it's really difficult to go backwards. So you want to catch patients well before then.
Yes. And I think that's the challenge, but it also is, part of that detective work that we do is trying to like, identify because I think you may remember if one of my students presented on a case of that huge Tarlov cyst that was in the lumbar sacral spine. And, she had been and she's like, I can't believe my gynecologist diagnosed this.
Well,
She did have vulvar dysesthesia, and that's why we went down that path. But
I mean, she's lucky to have somebody like you because it's really fascinating to me how the human mind works because when I look back on it, it is obvious that this would be the case. You know why?
mm,
Patients with spinal cord injury, they have sexual dysfunction as well as incontinence and
yeah,
inability to control their
yeah,
bowel and bladder. If you
right,
ask them, they have sexual dysfunction.
yeah,
And then patients with an entity called cauda equina syndrome. So that's like a medical emergency. It's
right,
usually when somebody has a huge sudden herniated disc, like an
uh-huh,
acute sudden event, and you go from being normal to like all of a sudden all your nerves are squashed. You
yeah,
show up to the ER with severe back pain, saddle anesthesia,
like,
like
yeah,
your butt area, your perineum is numb. You have burning pain down your legs, and you have either urinary retention or urinary incontinence or some type of urinary dysfunction. It's a surgical emergency. I spoke with a neurosurgeon that takes call to deal with those patients, and she just happens to like, oh, I see so many cauda equina patients. We're the referral center for cauda equina syndrome. And I
oh,
asked her, what proportion of those patients have sexual dysfunction? She didn't even hesitate. She
mhm,
answered immediately 100%. She goes like this, 100%.
oh,
So
yeah,
cauda equina patients have sexual dysfunction. And I bet you the Tarlov cyst patients had sexual dysfunction before urinary dysfunction. And then there's a really prominent Tarlov cyst surgeon in Texas. He
mhm,
reported on his group of patients. Oh, and by the way, a bunch of them had sexual dysfunction that got better. So when you go back and look at it, it
yeah,
is not a mystery that
mystery, yeah. We
that
just didn't
there's a
communicate.
neurologic cause. Yeah.
Yeah, we
One of
just
the
didn't.
causes of sexual dysfunction is going to be neurologic.
Yeah, yeah.
Why it took this much effort to convince somebody like me. And by the way, I've not been able to convince my colleagues yet.
I was
I'm
gonna ask.
slowly
Didn't you?
chipping away at the stone.
Yeah, but didn't you recently present at one of your conferences?
Yes. So I presented
Yeah. I'm like,
at a
yeah,
got asked to present at a Japanese um, spine association conference. They specifically asked me to give that talk, and I
yeah,
have no idea how it went over because it was. But
yeah,
I just submitted an abstract to ORS. It's like a really academic society called Orthopedic Research Society. These are like hardcore scientists
yeah, yeah,
on the TarlovCysts report. But before that, I have a lot of colleagues, and I
yeah,
mentioned it to them. I
yeah,
also have posts,
yeah.
and none of my colleagues will even acknowledge it. When I bring it up, they immediately divert the topic to something else. It's
Oh my
really
god,
clear
that's
they
yeah.
are not ready
They're
to
not
hear
ready.
this, but
Yeah.
I'm just slowly chipping away at the stone because we've been at this for 8 years now. This is
Yeah.
real. So
This is
now
real.
I'm like starting to submit. We're writing up another paper, and another two more papers, and submitting it to journals. So hopefully, we will slowly start getting a few other spine surgeons to accept this, to start looking at this,
Yes.
so that a lot of my patients on the East Coast, they really have a hard time because they have to schlep
Totally.
all the way over to San Diego for me to do their surgery because they cannot find a surgeon that's willing to do it. You can't even
Yeah.
find a surgeon that's willing to like see them and talk
Right.
to them about
To
this.
entertain it. Yeah, exactly.
I was like that. I get it.
Yeah, yeah. No, it's true, and I think, because my husband is an interventional pain doctor, like, I've convinced him enough, but I think that, like, when he tries to convince the orthopods and the neurosurgeons he works with, it's always like he's like, "I don't know. I can't do anything."
No.
He's like, "Tell him that
It's like everything. At
your wife
first,
is
they
crazy."
ignore you, then they fight you like it's offensive, and
Yeah,
then they act like everyone, it's always been like that. What are those three or four phases like?
but I guess
It,
if you publish it enough, then eventually, like,
yeah.
people will start believing that, this is
It,
this.
this is real. It's
Mm,
gonna happen.
yeah,
We just have to. It's just gonna take time to convince people. I went through something, and I'm going through something really similar because before this, I was at the forefront of a male invasive surgery called endoscopic spine surgery.
yeah,
Same thing. People think I'm crazy. What do you think we do in the knee and the shoulder and the abdomen?
yeah,
We don't do open surgery anymore. So for us
right.
to think like that's not going to happen in the spine, it's like, hello,
Yeah,
that's not
get with it.
reasonable. It's going to happen.
Right, yeah.
So it took me 20 years to convince people, but now there's like this little army of young spine surgeons that
Mhm.
are so into endoscopic surgery. They treat me like Obi-Wan Kenobi. And I bet you in another 20 years, there's going to be a small cadre of, you know, spine sexual medicine experts that will be looking at me like, I remember when you told us about this 20 years ago and I thought you were
Yeah,
crazy,
yeah, yeah.
but it's
And
going to
it's
happen.
and it's just sad because, the PGAD patients and the pelvic dysesthesia patients are the ones that really like, because it's hard enough for them. Like I have patients that will like literally cry that there's even a word to describe what they've been experiencing their whole life, right? Like this is such, just, oh wow, this actually is something that's not something that is in my head because women are told so long that everything is in their head, and it's just like, if you're continuously being told this, then you're actually believing it after a while. And then, of course, the brain does get involved. There's like that
Yep.
fifth aspect where it gets involved and it gets centralized and all this stuff. But
If I had PGAD, I would go crazy.
oh, crazy
My
for sure.
life would be literally upside down right now. I probably wouldn't be able to be the person that I am now. Not even
Right.
close.
And like,
I thought about it. I could if I had like, sciatica.
yeah, you can
I mean,
continue
I
with it.
could do a lot with
Yeah.
a typical spine problem,
Yeah.
but PGAD or something similar to that, it would be exceedingly disruptive
Totally.
and it would have a huge effect on my quality of life.
Absolutely.
And I had to think about it for a while.
Hmm.
And now I can, my heart goes, and I think everyone at Ishwish has come to the same conclusion. And that's
Yeah.
why everyone at Ishwish is so motivated because they
Yeah.
realize what a huge deal this is.
Huge. Huge. And I remember talking to April and, just how, like, it was such a transformative experience, and, she was and it happens to a lot of former athletes, right? Because she was, like, a former soccer player, and, like, all these people who like, gymnasts, all these people who have all these athletic histories, and no one actually looks in that. I remember and I told April, I was like, "I remember when you came to the conference and you were presented as like, one of the patients." And she actually, like, came to one of the conferences to tell her story as a patient, and her
I
husband was there.
remember that. That was
Um,
probably one of my very first conferences
the
too.
first one, right? Yeah, and just to see, like, how and I mean, now she's like a warrior. She's, like, doing all pelvic floor stuff for all these I send her so many pelvic
She
floor.
helps so many of our mutual patients. It's crazy
Yeah, but
because
it
the pelvis is complicated. It's not like your
totally.
foot or your ankle. I mean, that's like checkers.
Yes.
The stuff that goes inside your pelvis, it's like
I mean, it's like everything.
chess.
Yeah.
Yeah, there's
Totally.
a lot of things are autonomic,
Yeah. Yeah.
whereas your foot, it's mostly somatic. I can like tell it to go up and down. I can't tell my bladder to contract.
Yeah.
It
No,
like kind of knows on its own. I mean, I
it's on auto.
like to think I have control over my sphincter, but
Yeah.
besides that, everything else is kind of automatic. And so you can imagine how complicated things are in there and how
Mhm.
hard it is to treat those conditions. And by the way, at least most of the patients that I take care of, by the time they get to me, they're like the most unfortunate group of patients that have not just one thing. It's not just the spine. They
Yeah.
usually have something else. They
Right.
almost all have pelvic floor dysfunction because I think
Yeah.
you just get pelvic floor dysfunction after a while.
Yeah.
Sort of like I probably have some kind of problem with my leg muscles if my ankle is constantly bothersome.
Yeah.
Um, and they may have a little bit of hormonal problems. They may have a little bit of like local problems. Um,
Then they
so
have
it's
anxiety on top of that.
multifactorial.
Right. And then they
And,
develop
and then,
anxiety.
yeah, and then they get very anxious.
Yeah.
And anybody that doesn't think the mind has an effect on your physiology,
Yeah.
they
Go
haven't
back.
thought about it enough. And
Right.
then two, your mind on your sexual function.
Yeah.
I can have one random thought and it'll affect me in
Yeah.
a big way. So it is both fascinating
Yeah.
and challenging at the same time because it's so complicated.
Do you, because I mean, I only treat women, but I know, Irwin treats both sexes, obviously. Do you see a lot of men with this as well?
Yes, but PGAD seems to be more common in women. It's
Yeah.
definitely true. And
Yeah.
then men have like,
The hard flaccid and
yeah, they have a few other weird neurologic disorders that we're not really sure how to best treat them yet. But one of them is these really painful nighttime erections
mm,
that we can't figure out. And then something called hard flaccid syndrome. And then there are a group of patients with, it's not erectile dysfunction exactly. It's like orgasmic dysfunction where it's a little bit of both. So they have a little bit of erectile dysfunction, which is not the same thing as orgasmic dysfunction, but they have a little bit of both. So we're
right.
struggling through those patients. I would
Right.
say that our greatest successes have been in our women patients. And they seem to be the most distressed anyway, so it works out well. But we have so much work to do in this
Absolutely.
field. It's crazy.
Absolutely. Um, do you want to talk a little bit about how the annular tears came into the equation? I mean, with in terms of like what it
Okay.
is, how it might present, and how you went about treating that?
The annular tears are, by the way, the most common cause of PGAD in my group of patients. So I've probably done well over 100, probably 150 surgeries on the disc,
Hmm.
um, and 20 or 25 surgeries on TarlovCysts. So
Yeah.
the majority of the problems that we find are in the discs. So an
Right.
annular tear is probably the first thing that happens to a disc as it starts to wear out and degenerate.
Hmm.
And before you have a frank disc herniation. So the disc has two parts. It has the central core called the nucleus. It's gelatinous and it's in some ways kind of like the shock absorber.
Right.
It's surrounded by a thick ring of crisscrossing collagen fibers called the annulus. And that kind of holds everything in, but it's really thick. And it also has weight bearing support too. It rings it, sort of like steel belted radial tire. But
Yeah.
over time, with cyclic loading and gravity and bad luck and genetic predisposition, you can start developing fissures and cracks. And the nucleus can start like migrating in and getting trapped inside those fissures. And if any of that either leaks out a little crack to the outside world, or it stretches the outer part of the annulus because it's, with the fissures, it gets weak because it gets pressurized.
Right.
It activates these nerve sensors on the outside and tells the body something's wrong and initiates a healing response. And when you
Yes.
develop an annular tear, you probably have that, oh, I think I overdid it. I have a really stiff back and it lasts for like 2 weeks and then it gets better.
Hmm. Hmm.
When the annular tear heals, you're better. But if you get an MRI a month or two later, guess what? It looks exactly the same. It looks like, oh, wow, that looks really bad, but
Yeah.
it's asymptomatic. So
Yeah.
most annular tears we see on MR imaging are asymptomatic because most patients have gone through the healing process. But there's a small proportion of patients where that annular tear did not go through the normal healing process and the inflammatory process never turned off. It just stayed turned on. And that's what a symptomatic annular tear is. The majority of those patients, by the way, have back pain going down their leg. That's my normal practice. Patients with back pain going
Those are
down
very,
their leg.
yeah.
By the way, even to this day, I don't routinely ask them about their sexual function because it's still awkward, even
Yeah.
for me.
Yeah.
So for me to ask my colleagues to start asking their patients about sexual dysfunction, that's
Yeah.
just not going to happen. And then the patients don't feel comfortable
You don't
asking
want
about it.
to,
I
yeah.
had to
Yeah.
administer a written survey and
Yeah.
go, here you go, just fill it out. I'm going to leave now. And I'm not going to even ask about it. Just
Mm.
don't even write your name. Just put your initials and your date
Right.
in case I have any questions. But I'm not going to even try to. That's how I had to do this survey to confirm that people didn't get defensive and go, I don't have any sex. I wanted to really think about it. I didn't just ask them, did they have it or not have it? It was
Right.
like a little questionnaire with
Exactly.
threshold. Anyway, finding that group of patients that have a symptomatic annular tear from an asymptomatic one is no different than trying to figure out a symptomatic Tarlov cyst from an asymptomatic Tarlov cyst.
Sure.
In fact, it's even easier because we can do an injection. You know, I'm sure everyone knows the spine sits like this, right? This is a front view. If you look at the side, those are the discs right here, right? There's a natural opening called the neuroforamen. So the central canal is right here.
Yep.
That goes all like straight up and down.
Yeah.
And then at each level, a nerve root comes out and goes to different parts of your body, right? So in your pelvis, it's like a little bit of S1, a little bit of S2, a lot of S3, some of S4, right? But they all go down and then they exit at each places. Now, if you have an annular tear there and it's like a little inflammatory storm, then two things happen. One, the nerve gets stuck down. And just if you put a piece of tape on your neck, by the end of the day, the skin underneath that tape will be so irritated because it just gets pulled on. So the nerve gets irritated just from being stuck down to the inflammation. And then the inflammation just has like, it turns things on, just like how plantar fasciitis hurts. And
Yes.
so any nerve going by any of these discs can be irritated. And if it just happens to be the S2 and S3 nerves, guess what? Your experience will be in your pelvis. If it's irritating the S1 nerve root or the L5 nerve root, it'll be in your leg. That's the
Right.
sciatic. If it's S2 or S3, it's in your upper thigh. And so turns out a lot of our patients, they don't have both back pain, leg pain, and pelvic problems. Majority of the patients have one or the other and not
Yes.
both, just because of serendipity.
Right.
And so
That's interesting.
the injection can be done right at that level to bathe the annulus and bathe the annular tear.
Yep.
And
And they get
if the
temporary
patient
relief.
gets temporarily better, then I have the most awesome, most minimal invasive surgery, the laser endoscopic surgery, which is even way less invasive than a Tarlov cyst surgery. So that's been the best part of this whole process, that I've been able to use the most minimal invasive surgery that I have
Yep.
to identify a really common group of patients that historically people didn't know how to treat.
That's wonderful. I mean, I think this is like the best story ever. Like just in terms of, I mean, I have to tell a side story. When I was after my pregnancy, my second child, I started doing CrossFit. So do you see a lot of CrossFitters?
Yeah,
My husband's like, CrossFitters keep me in business. But like
they
the
do.
reality, yeah, you do one bad deadlift and that's it, right? Like that's how I herniated my L5S1, and I had all these crazy symptoms, which were awful. And but I think the reality is like your disc doesn't always just go back to normal either, right? Like that's just
No. Once you injure a disc, it's forever injured.
it's a forever injury. So like if I have a 5 pound weight gain, that's it. Like I'm feeling all the pain.
Yep.
And so, I think that's something to remember too is like take care of your back because, once you start doing some of that stuff, it's never gonna
That
be.
is so true. And unfortunately, it's something that is readily doable, but it's at the same time the most difficult thing to do. You know what that is?
What's that?
Getting really healthy and fit and exercising on a regular and consistent basis.
Oh, yeah.
It
Doing the
is so obvious that that's all you have to do, but
Yeah,
it is impossible to get people to do it. And
yeah.
I'm one of them.
Yes. No, it's hard. It's hard to keep
I've been having such back problems for 6 months. And I keep
Yeah,
telling myself, I got to get back to my
that's
exercise
a
program. And I just keep on making excuses.
yes, because it's just that one bad movement. I mean, I can still remember that deadlift that I don't do deadlifts anymore, but I still remember, like, trying to and, yeah, I just feel like, we have to be cognizant of our movements because,
Yep.
that's
I
why
like to
when
think of CrossFit not as exercise, but as a sport,
Yeah,
because it's like a sport.
it
You
is.
can get injured. If you're healthy, it's a great sport, but it's not a great sport to be fit. you need to do other stuff so that you don't get injured during CrossFit. So
So true.
that's how I tell people. I say, well,
Yeah.
that's not a good
Yeah.
exercise regimen. That's a sport.
Yeah. It's actually true because I try to do it postpartum. Like, I was like 12 weeks postpartum. It's like, no,
Yeah.
I don't ever recommend it. Start with Pilates.
If you're not injured, it's
Yeah.
like the best way to get really, really fit and be a warrior, but it is a high risk sport. It's kind of like golf.
Yeah. Yeah. Cause one bad swing and it's like,
Yeah, one bad luck swing, or you hit the ground too hard or something, or you just have a bad day,
yeah.
weird stance.
Yes. Absolutely.
It's awkward.
So Choll, tell us what advice do you have to number one, clinicians that are listening here to say like, in terms of evaluating, like what are some basic techniques of evaluating the spine that you would tell someone like me, a gynecologist who learned from my husband, like, but just so we know, because again, this is how we know like the back of the,
You know what I would say? It's really simple. Probably the simplest thing is to have a lower threshold on getting a lumbar spine MRI.
Mhm.
Because in the lumbar spine MRI, you can get most of the sacrum.
Yes.
And it's not like the olden days where these MRIs cost thousands of dollars. They're really inexpensive. It's
Yeah.
really get authorized. And if you go through the whole process of trying to assess somebody for their pelvic problem and you kind of are at the end of the road of thinking of anything else, I just get an MRI. And by looking
Yeah.
at the MRI, if there's any abnormalities, then
You could,
um, it may be an avenue for treatment because there's no physical exam finding, no consolation of symptoms that um, would be pathognomonic or even suggestive of the diagnosis. It almost always comes down to like an index of suspicion and having ruled out all other more obvious potential causes, and you're kind of at the end of the road.
yeah,
Now, if you're like 30 or younger, the likelihood that the MRI will be abnormal is a lot lower. But anybody that's 30 or older, they're going to have abnormalities on the MRI that's worthwhile looking at.
sure. That makes sense. And so what I could say is for some patients who, they're trying to use their insurance to get their lumbar, sacral MRI, like just if you use like any kind of sexual dysfunction code, it's not it's not gonna
Yeah, I can see how that is because,
yeah,
our it's a
yeah,
whole nother huge topic of discussion on how we
yeah,
take care of patients. It's almost like our parents are the insurance companies. It's like we
yeah.
can't do anything without asking our parents first. Like decision we make, it's like, is it going to be okay with the parents? It's really distressing, actually.
True. That's true. And
It's
then you
really
have to
distressing.
you need to pay
You have to
people
talk in
money.
parent language. The parent language is they have to have some kind of dysesthesia. So
Yeah,
I would say pelvic dysesthesias. Um, because by that point, you're probably thinking like, this seems neurological because it's not hormonal, it's not local, it's not purely psychological.
right. Exactly.
Um, so try pelvic dysesthesias.
Yeah. And sometimes you can, I mean, because pelvic dysesthesias are a form of lumbar radiculopathy, we think at least.
Yes,
So you just have to
absolutely.
say
And then
lumbar
if a
radiculopathy.
patient has back pain, which a lot of people just do,
Yeah,
that's reasonable too.
right. So I think that's something important to say.
I think
Um,
that's probably the easiest thing. That makes things easier. Having to focus on symptomatology and things like that,
Make it difficult. Yeah.
it's a lot more complicated.
Yes.
And it turns out, at least now, we don't have a good answer for that.
Yeah, it's true. And then one piece of advice for the listeners, like if you're a patient that's struggling for this, like how do you go about getting someone to listen to I ask this to all the people I interview, like how would you go about telling a patient how to advocate for themselves for when they're with someone that's not going to
Well,
believe them? So,
we
I
are
know it's different for
we
you
are
because
so lucky to live right now and having
yeah,
discussion right now. And the fact that we're not in the same room right now having this awesome discussion is probably the single best thing. Use the internet to identify people that are experts in the field and seek them out. And it's worthwhile getting an initial evaluation by somebody that knows about this. In the olden days, it would be hit or miss because we didn't have a way to like research. But now you
right,
just go on to Google
yeah,
and you type in a bunch of
push,
stuff.
yeah,
You can set up a Zoom appointment. Like I do, like over half my patients' appointments are by Zoom and people like from all over the place.
yeah,
And even though they don't have surgery with me, at least they can get a lay of the land
abs-
and We do a lot of things locally, like all the injections tend to be by the local pain doctors. And through this mechanism, we could do two things. One, utilize technology to get the word out and increase
Yeah.
awareness. But
Yeah.
like on a grassroots basis, the local doctors are going to find out about it because they have a patient in front of them asking them like, there's a Dr. Choll Kim in San Diego that wants me to do this injection for this problem. Here's a letter. And if
Yeah.
you're bored, go on the internet and check out his YouTube channel.
Yeah.
That doctor will probably be much more likely to be convinced than a doctor sitting at some conference, is my guess. And
Right.
I've had many doctors reach out to me and go, Dr. Kim, this is fascinating. And
Yeah.
so little by little, I have like little pockets of colleagues, pain doctors and primary care doctors,
Yeah.
that like I save their information because if a patient comes from their region, I send them to them.
Yeah.
So
We're
it's
chipping away.
slowly growing.
Yeah.
So I encourage patients to not give up,
Right.
utilize the internet for people with and connect with people like you, and demand better because it's out there. And it just takes a long time for medicine to catch up. It's
It
not
does.
necessarily a bad thing. We don't
Yeah.
want medicine to be this fly by night. We try every crazy little idea and
Yeah.
everyone jumps on board only to find out that it was a bad idea. We want things to be slow and cumbersome in some things,
Yeah.
like government and medicine. So it's not necessarily a bad thing, but at the same
Yeah.
time,
It's
it is a
frustrating.
little distressing. But luckily, the internet helps that a lot because it kind of makes the world way smaller.
Mm-hmm. Absolutely. All right. Awesome. Well, thank you, Dr. Choll Kim, for being on my podcast today. I'm so excited for everyone to listen to this. Thank you guys for listening. My name is Dr. Samina Rahman, Gyno Girl. I'm here for my podcast, Gyno Girl Presents Sex, Drugs, and Hormones. Remember, I'm here to educate so you could advocate for yourself. Please join me next week for my next episode. If you have a second, please subscribe to this podcast. I'd love for you to be a follower and learn as much as you can about the things that we're going to talk about with all the people on our journey. Please review us on Apple or Spotify or wherever you listen to podcasts. These reviews really help. Review us, comment, tell me what else you want to hear to get more information. My practice website is www.cgcchicago.com. My website for Gyno Girl is www.gynogirltv.com. My Instagram is Gyno Girl, so please follow me for some good content. Additionally, I have a YouTube channel, Gyno Girl TV, where I love to talk about all these things on YouTube. And please subscribe to my newsletter, Gyno Girl News, which will be available on my website. I will see you next time.